والصلاة والسلام على أشرف خلق الله أجمعين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. Today inshallah I'm going to talk about CNS lower limb examinations. Steps only. You will open the door and you will go inside. You will get two examiners. After greeting them, you will don't go to the patients, go and wash your hands and go to the wall. Inside the wall, read the instruction. Examine the lower limbs, examine the upper limbs, then I will come to the patients. Hello, good morning. My name is Dr. Adam. I would like to examine you. During my examination, if you feel any pain or discomfort, please let me know. Is that okay? Then I will take 2 steps away from the patients so as to look for the general observation. But the first step, do this maneuver. Then for any walking aid, here there is walking aid beside the patient. Focus on it because this is finding. Then come to do inside patient inspection. Inspections do outside and inside. Inside you are going to look for wasfa. W for wasting, for any wasting. S for any scar. For a scar, raise the limb like this and feel below. Then F for fasciculation, like this. A for any abnormality, like biskefas, as example. 2 inspections outside, inside for wasting, scar, fasciculation, any abnormality. Then I will go to the steps of the CNS. Tone power reflexes.
Coordination cessation.
Tone power reflexes.
Coordination cessation.
Tone power reflexes, coordination sensation. This is the steps of lower limb CNS examination. Tone are 3 steps. Tone around the hip, tone around the knee, tone around the ankle. Around the hip, do you have any pain? Then I will check for the tone. Yes, there is a little bit resistance also here. Yes. Then tone around the knee, one maneuver, flexion, then extension. Also here, flexion. Yes, there is a resistance. That means this is telling me this is hypertonia. If it is high, it will become with you floppy. Then tone around the ankle here. Then I finish the tone. I will come to the second step, which is tone power. Can you raise your both legs up, please? Against gravity, طبعا. This is the maximum. طيب. Then I will come to the second step. Power against resistance. Up, down, out, in. 4 around the hip, 1 around the knee, and 4 around the ankle. 4, 1, 4. 4, 1, 4. 4. Up. Then down. Yes. Then out. Then in. Then around the knee. In. Out. Here also in and out. Another maneuver for in and out. And in, out. In, out. Another maneuver here. In and out. Then I will come to the ankle. Up, down, then in, out, in and out. The benefits of the shape of the weakness for these patients. Focus about the shape of the weakness. If the patient he cannot do flexions of the hips up, that means most like this is the flexors are more weaker than extensors. As example, up. This is the maximum up for him. But look for him down. Yes, he is stronger. The flexors are more weaker than extensor. Out. Very weak. In, very strong. That means the abductor is more weaker than adductor. The pyramidal shape weakness, 3. Flexor more weaker than extensor, abductor more weaker than adductor, distally more weaker than proximally. I finish the second step, which is power, tone power, reflexes. Reflexes, I will come to the reflexes, 3 reflexes. Number 1, by hammer for knee and ankle. Number 2, upgoing plantar reflex. Number 3, colonus reflex. I will come to the hammer. Here to expose of the muscle, varus, thigh muscles, then the tendon. Number 1, I will take it like that. Expose here nicely, then feel the tendon. Then after that, I will take hammer like this. Let the hammer come by itself. Yes, see? This is hyperreflexion. Again here also, expose, then feel. Expose, feel. Yes. Then I will come to the ankle. In the ankle reflex, different maneuvers are right, but no need to, it's simply do like that. Flexion, then gentle external rotation. Then I will come to push the foot up like that to put this muscle in stretching position. Then, see? Like that. It is better than to raise the limb above the others. Again here, simple flexions, then external rotations, gently. Then I will bring my hands like this. Yes. 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 Tone power reflexes. I finish the hammer reflex and I will come to the plantar reflex. Do you have? I will do like that. Excuse me. I would like to move these sharp objects on the heel of your foot. Is that okay with you?
No.
Then I will take it like that. Yes, from outside to inside. Yes, also here. From outside to inside. Here, if you focus with me, this patient's having upgoing plantar. An upgoing plantar is one of the signs of upper motor neuron lesions. That means the spinal cord or the brain is affected. I finish the plantar reflex, tone power reflexes. Reflexes 3, hammer for the knee and the ankle, and plantar reflex, and the last one is colonus. Like this, 1, 2, 3. Also here, 1, 2, 3. Do it like that. Tone power reflexes, coordination sensations. Then I will come to the second step, which is what? Coordinations. For the coordinations, there is 2 types of coordinations. While his eye is opening, if he can do it while his eye is opening, that is mean he is okay. If he can move the heel of the foot while his eye is opening, there is no problem. But while his eye is opening, if he do it like that, while his eye is opening, he is crossing his feet together, that means this is cerebellar ataxia. And if while he closes his eyes, he cross his feet, this is sensory ataxia. That means there is 2 types. Ask him, can you move the heel of the foot, of this foot, on the shin of this leg? Difficult, that means the coordination cannot be assessed because of the weakness. I will say to the examiner, the coordination cannot be assessed because of the weakness. In case that he can move this on this leg, here there is no problem. While his eye is opening, he can move it. Okay, no problem. I will ask him, do it while your eye is closed. If while his eye is closed, is crossing, that means this is sensory ataxia. Joint position is impaired. 2 possibilities. If he cannot do it while his eye is opening, this is cerebellar ataxia. No need to ask him again to do it while his eye is closed. If he can do it, if he can move his heel okay without any problem while his eye is opening, ask him to do it while his eye is closed. Tone, power, reflexes, coordination, sensations. I will come to the sensations. There are 4 modalities of sensations. Any sensation lost below the anterior superior iliac spine, this is peripheral sensory loss. As example, light, touch, beam, break, joint position, vibrations, any sensation lost below this area, this is peripheral sensory loss. Or any sensations exceeding the anterior superior iliac spine here and go up, this is sensory level. That means the spinal cord is affected. As example, if the light touch stop in the suprapubic area, this is T12. In the umbilicus, this is T10. In the xiphosternum, this is T8. In the nipple, this is T4. Even in the clavicle, this is, I think, C2 or C4. Then I will come to the second step, which is what? Which is, this is the light touch. Okay, I am going to feel you here. No need to bring the face. Do you feel here? In both sides, this side and this side. Do you feel it? Okay, close your eyes. I'm going to move to feel you. When you feel it, let me know. Close your eyes. Here, I will ask, do you feel anything?
No.
Okay, don't do like this. Do you feel? Don't do like that. If he is not want to, if he is not feel, he will feel by this. No need to do that. Tell him that when you feel it, let me know. In both sides, you didn't feel it. Feel it, yes. Okay, when you feel it, let me know. I will go up. I will go up. When you feel it, let me know. Yes, he feel it here. That means this is light touch is lost up to the xiphosternum. I will ask him, is it like above?
Yes.
Okay, I will come to the other limb also. When you feel it, let me know.
Yes.
Okay, same like above.
Yes.
Both of them on this side, same. All of them same. Then I will come to the. That means the light touch is lost where? Is lost up to the level of the xiphosternum. The light touch and beam break is telling me what is running anteriorly. What is the wrong? Where is the lesion? The spinal cord two anterior or posterior. The anterior part of the spinal cord is manifested by light touch and beam break, and the posterior by joint position and vibrations. Here, if you do light touch, no need to bring the beam break after it. Go for vibration to know what is wrong posteriorly. Here I know the light touch is telling me that there is sensory level, there is anterior column affection at the level of the xiphosternum. Is that okay? I will come to the second step, which is what? Vibrations. To tell me what is wrong posteriorly. Do you feel it?
Yes.
Yes, also here, both of them same. Close your eyes. When you feel it, let me know. I will come to the bony prominence. Base of the big toe, medial malleolus, anterior tuberosity, anterior superior iliac spine, xiphosternum, mid-sternum and the clavicle, and lastly mastoid. When you feel it, let me know. Yes? Okay, tell me if it is stop. When you feel it, let me know. Tell me when it is stop. Okay, imagine that this patient is anterior cord syndrome, by the way. Imagine that he cannot feel this. I will continue up. Imagine that. Make it complete. Do you feel? Okay, I will go up. When you feel it, let me know.
Yes.
Yes, you feel it? Yes. Okay, I will come to the other board. Like above? I will come to the other board. When you feel it, let me know. Don't examine above the clothes.
Yes.
But this patient, he has got sensory loss for two modalities. Vibration from the posterior part and the light touch anterior. This is complete cord affection. Then I will complete my all four modalities. I will go to the Bimberic, then I will go for joint position. For Bimberic, I will do same maneuvers for the Bimberic. I will do same maneuver for Bimberic. I will no need to touch in the face. I will touch in the clavicle. Then I will come to do same what I did it in the light touch. Then I will come to the joint positions. In the joint positions, this is when in my side I will put this to separate the big toe from the other finger. This is up, this is down, and this is up. Close your eyes. What is this? And this? Okay, this is up, this is down, and this is up. And here, down. Then I finish my steps. To sum up for you, the examination of CNS is in the lower limbs. Outer inspections, inside inspection for WASFA, wasting scar fasciculation, any abnormality. Then I go for tone power reflexes, coordination sensation. If you would like to pass, train yourself on the maneuver of examinations, different maneuvers in YouTube's. Take for you only one maneuver, all of them are right. Print it in your brain, and after when you go to the exam, you will go what? You will go only for picking up the finding. Your brain will not be busy with steps of examinations. Then as soon as you finish, present your case, and if the time is allowed and you finish, tell the examiner, I would like to complete my neurological examination by examining the upper limbs, cranial nerve, cerebellum, back, and the gait. Would you like to add anything? What is this? Thank you. Goodbye. Another session.